Thank you for rejoining, and good evening to everybody. It's good morning to me in Los Angeles. So I'm going to talk about novel cardiovascular risk factors. So really kind of emerging cardiovascular risk factors that go and above and beyond the traditional cardiovascular risk factors today. I have no disclosures related to this lecture itself. I do have research funding by the NIH and then small society funding as well. So to get started and look at an overview, there are alarming risk factors specific to women. Cardiovascular disease remains the leading killer of women both in Europe as well as in the United States. Nearly every 80 seconds, a woman is dying from heart disease, and heart disease and strokes actually kill more women each year than all cancers combined. So all even the major top cancers combined, despite there's a lack of connect with women actually recognizing that heart disease is the leading killer. And over the past 3 decades, cardiovascular mortalities declined both in men and women in a good way. The gap is actually decreasing in disparities of number of deaths of women per men. And that gap is closing, especially in the women over the age of 65 years. However, in younger women less than 55 years, about over the last 7 to 8 years, there's been a plateau in deaths. And now that we are starting to see a slight increase in women aged 35 to 44 years. So are what we're doing for cardiovascular risk factors enough to capture the risk in these young women? So briefly, the traditional cardiovascular risk factors, both in men and women, include hyperlipidemia, hypertension, diabetes, smoking, obesity, inactivity, and family history. You can see that women are less likely to achieve lipid goals than men. 80% of women over 75 years of age have hypertension, yet staggering only a third of them are actually well controlled for adequate blood pressure, and even less now considering the updated hypertension guidelines. Diabetes confers a 45% increased risk in women for ischemic heart disease, as well as smoking confers a 25% increased risk. So how are we currently estimating the cardiovascular risk in women? It's usually using risk scores that include all of these traditional cardiovascular risk factors, whether it's in the United States using the ASCVD risk calculator or the heart score in Europe. Both of them are very well vetted, including things like gender, age, cholesterol, body mass index in the score, as well as treatment for cholesterol, diabetes, and if the woman's a smoker. So this will give you a one-time pinpoint within the office to estimate a woman's cardiovascular risk. But what about traditional risk factors and novel risk factors? So you can see the traditional ASCVD risk factors are on the left-hand side of the heart. But what we're going to talk about today is more of the non-traditional risk factors that aren't even captured within these risk scores itself, that might be explaining some of those elevated death rates and incline in women 35 to 44. So to first start off, let's go through what happens during pregnancy. So anything from preterm delivery, hypertensive disorders of pregnancy, which includes preeclampsia, eclampsia, as well as gestational diabetes. I'm going to focus on first preeclampsia. And so what is preeclampsia itself? This is new onset hypertension. So going into pregnancy, normotensive, usually after the 20th week of gestation, systolic blood pressure raises over 140 or diastolic over 90, and severe would be defined as greater than 160 over 100. So this would be accompanied with a new onset of proteinuria, which is also changed. You can see the second bullet. You can actually have an absence of proteinuria to actually be defined as preeclampsia or eclampsia. But it's a multi-system organ impact in terms of what occurs. You get extremity edema, liver function abnormalities, thrombocytopenia, pulmonary edema, and visual disturbances presenting with the presentation of cerebral edema. So a multi-system organ dysfunction that's occurring during pregnancy, and we now know that the treatment is to deliver the baby. I'm going to bring this back to cardiovascular disease and how it could possibly be a risk factor for cardiovascular disease by talking about the hemodynamic changes that occur during pregnancy itself. So you follow the red line, this is cardiovascular output, or cardiac output, excuse me. And the first trimester, when a majority of gestations occurring, the cardiac output is pretty stable, but towards the end of the first gestation, there's a rapid increase to impact during the second and third trimester, where blood volume increases, heart rate increases by up to 20%, and that all increases the stroke volume. And this is consistent throughout the second and third trimester. And then you can see postpartum, there's also a rapid decline. So what's occurring during the third trimester is what we would liken as a cardiovascular stress test of a woman that's over 9 months long. Well, what's happening during a cardiovascular stress test, to bring it back to the hemodynamic changes? So for stress testing, we put a woman or a man on a treadmill test or a reclining bicycle, and every few minutes the elevation increases as well as the speed increases. So over time, you can see the heart rate will increase, and the duration of most stress tests are anywhere from over 8 minutes to 15 minutes, but we want to get to 80% of a predicted maximum heart rate to consider it to be a good test. Age predicted of about 90% is considered an excellent test, but as the exercise progresses, skeletal muscle blood flow increases, you get oxygen extraction that increases as much as threefold, and then peripheral resistance decreases, systolic blood pressure, mean arterial blood pressure, as well as pulse pressure increases. So this is similar to what occurs over a 9-month period of a pregnancy. And of course, we look at EKG changes during stress testing to see if the woman has passed or not passed. Well, what's happening during the physiology, the pathophysiology of preeclampsia, and how could this be a vascular dysfunction? Well, it's complex, it's not well understood, and we know it's a pregnancy-specific disorder, specific to how the placenta will implant. So on the far right of the screen, you can see there's a normal pregnancy implantation of the placenta itself. And what happens is it invades deep into the trophoblastic and the myometrium level. What's believed to occur during preeclampsia is there's only level of invasion, there's an inadequate level of invasion to the myometrium, and the level is at the trophoblastic invasion area. So it's the implantation that is not sufficiently implanting and improperly that leads to this angiogenic imbalance. So you have stage 1 would be the defective placenta that you could see in the box. Over the first trimester, you don't have the demand, that upstroke in cardiac output. It's only until the second trimester that you start to see that dramatic upstroke in both heart rate, blood pressure, and cardiac output. And because of the implantation that's not properly occurring into the myometrium, you get placental ischemia. And that results in vascular and placental growth factors that decrease. And then you get, in addition, you get significant systemic hemodynamic adaptation. So the body is trying to adapt to the fact that the placenta is not vetted into the myometrium itself. So it's believed that the placental ischemia is thought to promote the release of the anti-angiogenic factors, and then endothelial cell dysfunction leads to an instability of the vascular tone with vasospasms in many different organs itself. And then that activation occurs, and you get activation of the coagulation cascade, and you get microthrombi and formations in many different organs. The endothelial dysfunction is considered stage 2, and then you get the reduced perfusion to the affected organs, and then the clinical manifestation of preeclampsia. So what is known about preeclampsia? What are formal risk factors for preeclampsia? Well, a lot of them overlap with traditional cardiovascular risk factors. So having chronic hypertension, almost a 4-fold increased risk a woman will develop preeclampsia, and diabetes, about 3.5-fold, and a family history of heart disease. So a lot of overlap in terms of what's vascular dysfunction risk factors, as well as formal risk factors for preeclampsia itself. So the change in parity is interesting. It's actually an 8.6-fold increased risk. So having a different paternal side for each gestation also increases that risk factor by 8.6% in fold rates. But what comes first? Do these women enter pregnancy with vascular dysfunction, given that they might have an elevated cardiovascular risk itself? And then does that then lead to preeclampsia? And should that be an early marker for women at high risk for cardiovascular disease? Or is vascular dysfunction occurring during pregnancy? Women enter with healthy vascular function, and then the actual impact of the placenta, not the defective placental implantation, does that precede, does vascular function then occur postpartum? So is it really the chicken or the egg? And this hasn't been answered yet, likely because a lot of the prevalence of preeclampsia in the United States and most developed countries is about 3 to 4%. And so following these women pre-pregnancy is what's going to be important to answer this question. So what about preeclampsia and ischemic heart disease later in life? Well, a very large meta-analysis of both prospective and retrospective cohort studies were included in this data set of over 3.5 million women. About 200,000 were affected by preeclampsia. They were the exposed group. And there was about 30,000 episodes of cardiovascular disease in the study. So you can see that there was an overall meta-analysis that showed the relative risk of developing ischemic heart disease later in life was about 2.1-fold increased risk, or 2-fold increased risk. It was really one of the first signals published in 2007 that showed that there was this association. Now, I mentioned preterm delivery was also a risk factor for cardiovascular disease, but it's also been shown that preterm preeclampsia is even a greater mortality to the mother. So having no preeclampsia and a term delivery is in red, and these are 25 years follow-up from first birth. But the worst is if you have a preeclamptic woman and a preterm delivery, the survival rate is dramatically different compared to no preeclampsia. Now, coupled with preeclampsia, small gestational age, and preterm delivery, looking now at major adverse cardiovascular events, which in general includes non-fatal MI and coronary death in this large registry-based study that was published in 2017. These were women aged 16 to 49 who gave birth during about the 1980 to the early 2000s, and they were registered in this Norway registry. They were followed prospectively for 29 years, and they were looking for incidental major coronary events and mortality. So you can see that women who had preterm preeclampsia in the red now had a 5-fold hazard ratio for having a major adverse cardiovascular event. And then having just preeclampsia with small gestational age was a 3-fold increased risk, as well as just having preeclampsia alone was a 2-fold increased risk. So regardless of just having preeclampsia, if you now couple it with gestational age as well as preterm delivery, you have an increased risk. So what are emerging data to suggest preeclampsia? Well, these are smaller studies, but it's been shown that preeclamptic women maintain unfavorable lipid profiles later in life. So decreased HDL, small dense LDL, and higher apolipoprotein B. 3 years after diagnosis of preeclampsia, endothelial dysfunction has been shown to be impaired using brachial artery flow dilatation, so BART. So this is now looking at the postpartum, so that whether or not this preceded pregnancy or occurred during pregnancy, now studies are showing that there is evidence of endothelial dependent dysfunction 3 years after diagnosis of preeclampsia. 5 years after delivery, women with preeclampsia have persistent microalbuminuria. And then 17 years, higher rates of insulin resistance compared to matched controls, and a 3-fold higher risk of end-stage renal disease compared to those without preeclampsia. So all of these suggesting that there is emerging risk factors that occur after having a preeclamptic event. So what do guidelines say? Guidelines, whether the American Heart Association or the ESC, really do focus on the fact that if women have preeclampsia or a history of preeclampsia or pregnancy-induced hypertension, there should be screening for hypertension, and diabetes should be considered. And the US recommendations for cardiovascular risk in women, this should be considered a major risk factor for women if they've had a history of preeclampsia, gestational diabetes, or pregnancy-induced hypertension. So in our clinic, we've now developed a postpartum heart health clinic. So in general, we start seeing women with about 6 months after delivery if they were inpatient and delivered with a preeclamptic pregnancy, preterm delivery, or had gestational hypertension. And we're starting to screen these women early and finding a lot of women who have familial hyperlipidemia in addition to having no history of hyperlipidemia in the past. So the next traditional and non-traditional and emerging risk factor I'm going to discuss is autoimmune diseases, which is a new fascinating area that we've done some research in. But how could systemic inflammatory diseases increase the risk of cardiovascular disease? Well, a lot of this is confounded by the systemic inflammation that occurs along with autoimmune diseases. They're far more prevalent in women, therefore making it by default a novel risk factor for a woman. Rheumatoid arthritis has a 4% prevalence in women versus 2% in men, and lupus has a 10-to-1 predominance in women. Systemic sclerosis had an 82% increased risk for coronary artery disease when you compare them to age-matched controls. So you can see within all of them, all of these disorders, whether they're psoriatic arthritis, gout, rheumatoid arthritis, lupus, vasculitis, the underlying theme is a common inflammatory milieu that then increases the risk over time of developing plaque, obstruction, and coronary artery disease. But in addition, there's several medications that are associated that we use for treatment of autoimmune that can increase the risk of cardiovascular disease risk factors, such as glucocorticoids, increased blood pressure, increased triglycerides, and also, as we know, increased glucose and risk for diabetes. NSAIDs, so nonsteroidal, also increase blood pressure, and then they tend to also decrease renal function. So, but while others decrease the cardiovascular risk, so things that are working against the inflammatory response, so methotrexate decreases that risk. So Cardiovascular Inflammation Reduction Trial was a double-blinded trial of 7,000 men and women with stable coronary artery disease or metabolic syndrome, and showed that on methotrexate, there was a decreased outcomes for those that received the methotrexate versus placebo for cardiovascular disease. So a little bit of a busy slide, but to mention the fact that there is also a lot of immune inflammatory cytokines that are present, and more pro-inflammatory cytokines like IL-1, IL-6, TNF-alpha in all of these conditions, systemic and vascular inflammation that acts more synergistically. In addition to the accentuated traditional cardiovascular risk factors, like I mentioned, they were more prevalent in inflammatory rheumatic diseases alone or due to the treatment itself. For example, if a woman has an elevated TNF-alpha level, usually seen such as rheumatoid arthritis, that may promote insulin resistance. So you see the synergistic effect that's occurring. Patients with lupus commonly actually have more hypertension. Probably that's due to the renal involvement as well as the concomitant use of corticosteroids, as I mentioned. So we and others have looked at the microvascular flow to the heart in women with autoimmune inflammatory conditions. And this was first brought to our attention in 2012, where we were imaging women who were complaining of pleuritic chest pain. And in the cardiac MRI, this is a cardiac MRI now, no radiation, we were looking at the subendocardial flow to the blood, which would be consistent in a circumferential pattern of microvascular disease. So not obstructive coronary artery disease, but microvascular disease. So we found there was myocardial ischemia in the absence of obstructive coronary artery disease in patients with lupus. The panel D, actually, if you can look at, that actually represents the darkening. That's the circumferential ischemic changes that are seen during an adenosine cardiac stress MRI. And we found that there was a threefold higher risk for ischemic heart disease and morbidity and mortality in lupus. And we have shown this now repetitively and are working on a larger grant looking at adenosine MRI imaging that shows that subendocardial ischemia or microvascular disease. So this is such an important topic. The European League Against Rheumatism has now published recommendations for cardiovascular risk management in patients with rheumatoid arthritis and other inflammatory or joint disorders. So they're suggesting that if you're doing a risk score system, such as SCORE or ASCVD, they're underestimating the burden of cardiovascular risk in these patients. And they're suggesting a multiplier of 1.5 to that risk score to account for the elevated risk that's seen in this population. The next emerging non-traditional risk factor we're going to discuss is breast cancer treatments. And I touched on this at the last meeting, the EMAS meeting. There is a perceived risk that women are more fearful of breast cancer than heart disease. I can't move it, there it goes. And the most recent statement, which fully follows up from the European heart failure statement, which I'll close with at the end of this section, was from the American Heart Association. So while there's not been a position statement or guidelines, there is a scientific statement from the American Heart Association that talks about the entities of the intersect between cardiovascular disease and breast cancer. So the overall mortality and the cardiovascular mortality in women with breast cancer who receive over a 15-year period is elevated. You can see that in the dashed line, whether it's overall mortality or cardiovascular mortality, there is an elevated risk. Specifically after 7 years of use, there's an increase. Cardiovascular disease is evident at 7 years after diagnosis. And this risk has really been thought to be attributed to radiation or chemotherapy. But breast cancer survivors have almost a twofold increased risk of cardiovascular related deaths compared to women without cardiovascular risk, without breast cancer. So what are the consequences of chemotherapy? Consequences of chemotherapy is you're not actually hitting the target that is intended, or you're hitting the target that's intended, but you're also hitting other structures. So there's an acceleration of atherosclerosis via intimal medial injury, so that you get, and then that leads subsequently to myocardial infarction. You get fibrosis, which can lead to diastolic heart failure or diastolic dysfunction. Valvular heart disease can be a sequelae of the radiation itself, as well as bradycardia, heart block, sick sinus syndrome when it's hitting the AV node, or pericardial disease, pericardial effusions, or pericarditis can occur. A lot has been changed to guidelines and treatments for radiation therapy. And the radiation therapy and coronary risk is very correlative to the gray units of ionizing radiation. So as you can see, the mean dose of radiation to the heart, which is the gray unit, the incidence of major coronary event increases dramatically as we increase per gray unit. So every increase per gray unit is about a 7% increase of major cardiovascular disease events. So this was seen in 2,000 women. And you can see this is up to 2001. So a lot has been changed since these publications, but the mean dose to the whole heart for this study was 4.9 gray units. But pre-existing conditions, cardiovascular risk factors, having breast cancer on the left side of the chest, radiation to the left side versus the right side, and receiving concomitant chemotherapy and the supine radiation. So now the dose is 1.37 gray units, and there are procedures, heart-sparing prone positions where women are receiving radiation. But there's a specific definition of cardiotoxicity in women who are undergoing chemotherapy or radiation. So, and this is if there's an ejection fraction greater than 10% decline. So the final ejection fraction is less than 53% from start of treatment, or there's a global strain reduction of greater than 15% seen on imaging, or an elevated troponin, cardiovascular troponin, ultrasensitive cardiovascular troponin 1, or an elevated BNP or NT-proBNP, so elevated. And there's a lot of consequences of chemotherapy. It's not just the use of radiation itself, but you can see that a lot of the chemotherapies that we're still using today can result in cardiovascular consequences. So with that being said, the European Journal of Heart Failure has now also preceded the American Heart Association in 2011, looking at the cardiovascular side effects of cancer therapies. And this was specific to heart failure itself. So they're suggesting the use of simple biomarkers such as troponin and BNP should be considered, but not a substitute for objective evaluations or echocardiogram or other similar modalities. And in our cardio-oncology clinic, if we have women entering or undergoing treatment, these are markers that we use and can follow. So depression, let's go through depression as a significant risk factor for women. So heart disease and depression are amongst the most disabling diseases. Women are twice as likely to have depression than men. And as we are within the menopause society, women who have entered menopause and had a previous depressive episode, they're at a significant increased risk to have a depressive episode again. Women who are depressed are greater than 2 times more likely to have a sudden cardiac death as compared to women who are not depressed. Women with depression are more likely to have comorbidities of obesity, or they're more likely to smoke. And young women who are under the age of 55 with an acute MI experience more angina and depression, had a worse quality of life, and were less likely to return to work within 12 months after their MI. So I thought this was a really good chart to show that using the patient health questionnaire, so the PHQ-9, which is a simple validated tool, you can see the scores elevate all the way over to 27. But if you look at coronary artery disease, the proportion with coronary artery disease and depression is almost 70% if they have an elevated score. And then you look at things like cardiovascular death and cardiovascular events are much more dramatically elevated, and there's a statistically significant trend. And these were all patients that were undergoing coronary angiogram and followed over a 3-year period at under the age of 55. So there's a strong association between depression and cardiovascular disease. And while these are tools to use clinically, the PHQ-9, it's also important to recognize this and ask about depression, especially after a woman's had an angiogram or after a myocardial infarction. So there's an added risk factor for a novel and emerging risk factor. It might not be as novel as we think it is, but it's the premature estrogen loss. And mortality rates are declining except for women in age 35 to 44, and what would happen if the estrogen loss occurs during this period. So we know early menopause, less than 45 years of age, is associated with an accelerated atherosclerosis and almost little over 2.5-fold increased risk of cardiovascular disease. And this has well been studied in the Nurses' Health Study. So surgical oophorectomy under the age of 50, if women are not treated with estrogen replacement, they were at risk for not only coronary heart disease, but stroke and all-cause mortality, all-cause death. So this has become well accepted that women who undergo these certain surgical interventions or go into early menopause, premature menopause is recommended under the age of 50 to treat with estrogen. But what about young women who also have situations where they might have low estrogen states and not be in menopause. Well, hypothalamic amenorrhea affects 1.4 million young women in the United States. To put that on a same level playing field, that's the same number of women that is impacted by lupus. So what is hypothalamic amenorrhea? So this is absence of menses for 3 or more months in a previously menstruating female, so secondary amenorrhea. And it's usually brought on by a clustering or one emotional stress, over exercising, or restricted eating. So it can encompass all 3 of them, or it can encompass just one. And you can see that there's a lot of overlap. So these are young women who are walking around otherwise healthy, that have had 3 months or more of amenorrhea. They know they're not pregnant, or they don't believe they are, or perhaps they've checked. So they don't think of it, they're the walking well. They don't think that this is a concern. But what's happening in the brain is you get the GnRH, the LH and the GnRH axis is shutting off, and therefore you don't get the LH surges to then tell the ovary to produce estrogen. And in women who are exercising in more extreme athletic situation, that's more common, exercise-induced amenorrhea varies but can affect up to 25% of competitive athletes. So this is a condition that is not being discussed as much. Of course, with hypothalamic amenorrhea, you have to rule out other things like thyroid dysfunction, PCOS, prolactinomas, other causes for amenorrhea, because it is truly a diagnosis of exclusion. But in general, women have an estrogen less than 50, an FSH less than 10, and an LH less than 10. So they're walking around with very low serum levels of endogenous estradiol. So we've looked at this hypothalamic hypoestrogenemia in 95 women who were presenting premenopausally with chest pain. And this is the Women's Ischemia Syndrome Evaluation Study. All these women were not on hormones. They were presenting with chest pain, and they were being taken to the cath lab for evaluation and undergoing an angiogram. In these 95 women, 13 had coronary artery disease, but 35% had hypothalamic amenorrhea. So they had this milieu of estrogen less than 50, FSH, and LH less than 10. And what we showed was that no matter if a woman had obstructive coronary artery disease compared to no obstructive coronary artery disease, in general, overall, there was a statistically significantly lower levels of bioavailable estradiol, FSH, and LH compared to those that had no coronary artery disease in that 1/3. So I mentioned 30% had hypothalamic amenorrhea. So this is premenopausal women who all had obstructive coronary artery disease. 70% of the women who had obstructive coronary artery disease had hypothalamic amenorrhea as defined by those labs and ruled out for other causes compared to no coronary artery disease. So what is it that would make estrogen in a young woman unique? Because these are women who are athletic, they are healthy, they don't have the traditional cardiovascular risk factors. So if you look at this is a diagram of a barrel of a coronary artery. The one on the far left is normal artery with normal vascular function. And as you progress over to the right, you can see there's a normal artery, but then you get microvascular dysfunction. So the precedings of what we would consider coronary heart disease. And that's where the arrow shows. And then you get subclinical atherosclerosis progressing to obstructive disease over time. This would be the progressive manifestation of ischemic heart disease, where it goes from preclinical to clinical. But you can see on the far left, if we were to knock out estrogen, specifically in these young women, they're not then developing hypertension, obesity, and hyperlipidemia. So these are women who are otherwise skipping over that step. And is it an inflammatory milieu that then leads them on to develop microvascular dysfunction? So we've talked about the traditional risk factors for cardiovascular disease in both men and women, and how they impact. Traditional risk factors are impacted slightly more in women, and the emerging risk factors for women, such as autoimmune, gestational diabetes, hypertension disorders of pregnancy, including preeclampsia, early menopause, as well as estrogen loss in younger years, so hypothalamic amenorrhea, and depression. So in summary, the traditional cardiovascular risk factors and risk calculators are not capturing the risk in these young women aged 35 to 44. Adverse pregnancy outcomes should be asked when assessing cardiovascular risk in women. Autoimmune inflammatory diseases are more prevalent in women, and they also increase the risk for cardiovascular disease. And cancer survivors who receive cardiotoxic chemotherapies as well as radiation therapy are at risk for future cardiovascular disease. And women with depression are 2 to 3 times higher risk for cardiovascular disease than those that are not depressed. So I thank you for your time. I know and share the risk factors for heart disease in women, and I will open it up for any questions. So thank you.
All right, well, thank you so much for your presentation on these risk factors. And we do have some questions for you. Let's see, so the first one is that he had seen a patient today, age 70, with high cholesterol, 6.6, high triglycerides, BMI was 25, HX, doesn't know, TIA 1 year back, blackout, blurred vision, which recovered, not started on statin. Would you consider HRT for menopausal symptoms? And then let's see, I think in this case, risk outweighs the benefit, and she has tried alternatives to HRT.
So this, I tried to follow it really quickly. I'm trying to take notes. So it's a 70-year-old woman who has what I would say are a history of a TIA and risk factors for cardiovascular disease. I didn't hear when she went into menopause, but assuming if she went into menopause naturally around the age of 51. So she's over 20 years since menopause. And if you look at traditional or guidelines, the risk of starting hormone therapy is significantly elevated in women in their 60s and 70s. So therefore, I would not be prescribing her hormone therapy, and I would be prescribing, I would be looking at what alternatives she's tried. Hello?
Okay. All righty. And then the second one is PCOS and risk factors for cardiovascular disease. They would just like your comment.
So yeah, I think there's been a lot of research surrounding PCOS and traditional cardiovascular risk factors. And there was one of the last webinars was dedicated to PCOS. So I didn't focus as much on PCOS in this, but I think it's also important to look at women who present with PCOS. And there's actually a very good 4-question validated questionnaire to just determine if a woman is having hirsutism and irregular menstrual cycles. And I think those are women that we should be capturing early as well. But I didn't focus on it as much because it's been discussed as a separate webinar. Thank you.
All right. And then our next one, would you screen PCOS women for CVD? If yes, when do you start screening?
For PCOS, when would I start screening? Well, it depends on, sorry?
For CVD.
When would I start screening for cardiovascular disease? I think at every visit, it's vital for, to do a valid, blood pressure and check in terms of that. I would probably at least start at a younger age than healthier women. I think at the earliest I would look at would be at least in their 30s, and then perimenopausal as well. I would look at the clustering of cardiovascular risk within the family itself. But you're going to want to look at their increased risk if they have impaired glucose tolerance. I wanted to know if they would have gestational diabetes and other factors. Yeah.
Okay, and then in patients with, I know I'm going to butcher this word, hypothalamic amenorrhea, Would you recommend combining pill or HRT patches?
So that's a really interesting question, because if you look at the Endocrine Society guidelines or position statement on hypothalamic amenorrhea, they do not recommend treating with OCPs or birth control pills because it is a false sense of security that these women are having a menstrual cycle back. In addition, the data on bone is not, there's no improvement in bone health, and that's been well studied in this population of women, and specifically in women who have eating disorders. So there's no impact on the bone from the OCP. So the transdermal estradiols seem to be more impactful, but the guidelines really suggest to reverse the cause of the hypothalamic amenorrhea. And if it's been longer than 6 months, then to consider using a patch of estradiol. What I do is and this is where some of my funding studies from the NIH is we're looking at the impact of giving women back an estradiol patch of 0.1 and what that's doing to the vascular health. Is that improving vascular health? And these are women who've been amenorrheic for a long time, so our trial is looking at using it unopposed for 3 months, but clinically you would need to add in the progesterone.
All right, and then in RA, what is the mechanism of methotrexate reducing the risk?
Oh, the methotrexate decreasing the risk for, I believe it was autoimmune. It was decreasing more of the pro-inflammatory cytokines. I would have to look that up and get exactly back to you, but I believe it was more through the decreasing the inflammatory cytokines.
All right, well, I think that is, well, I'm sorry, we got one more. Let's see. Patients with hypothalamic, I know I'm going to mess that word up again. They need.
You could say HA.
Okay, all right, HA. They need contraception, excuse me, I'm sorry, to IM patients wanting to start HRT with family history of strokes and grandmother, an aunt in 40s. Is this a strong family history for someone wanting to start HRT?
So if you look at it in certain respect, these are women who should be having an endogenous fluctuation of estradiol. So just like we don't see an increased risk in breast cancer in women who use OCPs, you can liken that to the HRT. That's, without that being said, we don't have the data to back that up. But if there is a strong family history factor for more pro-inflammatory conditions, I would consider the transdermals, but I would also consider if there was, there are some statements out there about doing some screening for more prothrombotic risk factors or coagulopathies prior to starting HRT or OCPs. I mean, I wouldn't be starting OCPs, but if it was a young woman not with hypothalamic amenorrhea. So I'm comfortable because these women should be having their own endogenous estrogen, but I think every case is very specific. You'd have to look through the entire family history. So that's an excellent point.
Okay, and I'm sorry I messed that up. Those were two separate things. So patients with HA, they need contraception too. Was just a question.
Oh, but they need contraception once they start having cycles back, but they can actually have, so yes, that is correct. So if that's why the guidelines first say to try to reverse the condition that's causing the underlying condition, whether it's over exercise, under eating. So the transdermal estrogen would be a bridge to getting recovery, but they also they would need a contraception, which doesn't necessarily have to be an OCP, but OCPs alone does not reverse the causes of the impact on the bone health. And now we're looking at the vascular health.
Okay, and then what dose of estradiol patches, 50 mcg for HA?
So there's no current guidelines out there, but if you look at the average estradiol level of a woman who's having a menstrual cycle over a 28-day period, it's approximately 75 to 100 picograms. So that's why we are studying the impact of the 0.1 dose of the patch. But I think if you try to get a woman on estrogen, these are women who've been estrogen deficient, and sometimes they're very sensitive to their estrogen, and you could get them on a low dose patch at 50 and try to see, and then go up from there. But again, this is what the area of research is needed, and especially the area of guidelines in terms of recommendations.
All right, well, I think that is all of the questions. If y'all have any more, simply just type them in real quick. But we do want to thank you so much. This concludes the presentation and webinar. Thank you so much for your wonderful presentation, Dr. Shufelt, and all of the attendees for being here today. Just a quick reminder, you will receive a pop-up window after this session ends containing a brief survey. We appreciate your response, and thank you, everyone. And I hope you have a great rest of your day.
Thank you.
Thank you.